Langerhans cell histiocytosis, or LCH, is a rare and complex medical condition. Today we explore its pathology and the critical role of imaging in its management. Understanding LCH requires a deep dive into the cellular level and how modern imaging helps clinicians map this disease across the body. LCH is characterized by the abnormal clonal proliferation of Langerhans-type dendritic cells. It is now classified as an inflammatory myeloid neoplasm, reflecting its nature as both an inflammatory and a neoplastic process. The disease is frequently driven by mutations in the MAPK signaling pathway, most notably the BRAFV 600E mutation. A hallmark feature at the cellular level is the presence of Burbeck granules, unique tennis racket-shaped structures within the cells. While LCH can affect people of all ages, it is significantly more common in the pediatric population. LCH has a broad clinical spectrum, potentially affecting almost any organ system in the human body. Bones are the most frequent site of involvement, commonly affecting the skull, long bones, and the spine. Other common sites include the skin and the lungs, where the disease can present in various forms. Involvement of the pituitary gland is also significant, often leading to endocrine issues like diabetes insipidus. The disease can also manifest in the lymph nodes, liver, and spleen, indicating a more systemic involvement. Liver, spleen, and the hematopoietic system are considered high-risk organs, requiring more intensive management. In contrast, involvement of only low-risk organs like the skin or isolated bones often carries a better prognosis. A definitive diagnosis of LCH requires a biopsy to confirm characteristic histological features. Pathology looks for positivity in markers such as CD1A and CD207, also known as Langerhans. While biopsy is the gold standard, imaging is vital for mapping the extent of the disease throughout the body. Traditional modalities like X-ray and CT are useful, but 18-FFDG PET-CT offers unique advantages. PET-CT can detect hypermetabolic, FDG-avid lesions that might be missed by conventional scans. It provides a comprehensive whole-body evaluation in a single scan, improving staging accuracy. By detecting occult lesions, PET-CT frequently leads to changes in risk group classification and treatment decisions. Crucially, metabolic activity often decreases much earlier than anatomic changes, making PET-CT ideal for response assessment. It also helps clinicians differentiate active disease from residual scar tissue or inactive lesions. However, PET-CT has limitations. It is less sensitive for certain cystic and nodular lung lesions where high-resolution CT remains superior. Similarly, brain and pituitary involvement are better evaluated using MRI. Clinicians must also carefully consider radiation exposure, especially when managing pediatric LCH patients. In summary, PET-CT is a powerful tool for the staging, monitoring, and follow-up of Langerhans cell histiocytosis. A multidisciplinary approach is essential for optimal care. Subscribe to Project Health MD for more evidence-based medical education.